Good morning. I'm Namrata. I'm presenting on behalf of Medicine 2. My clinical meeting presentation is titled Stauff to Think About. So Mr. R is a 47-year-old embassy employee from Calcutta who presented with fever, cough and breathlessness. Fever for 3 months, cough for 2 months and breathlessness for 1 month. Fever was high-grade intermittent, cough was non-productive and there was no hemoptysis, and breathlessness was exertional. There were no features suggestive of heart failure, no frothuria, anasarca, abdominal distension or jaundice. He also reported a significant weight loss from 86 kilos to 78 kilos over the past 3 months, along with loss of appetite. He is unmarried and he had no other comorbid illnesses and 2 prior lithotripsies. There is no family history of malignancy and no contact with TB. On examination, he was mildly tachycardic, pulse rate was regular and all peripheral pulses were present. Blood pressures were 130/70, respiratory rate was 16. He was pale and bilateral axillary lymphadenopathy, 1 centimeter was present. No skin lesions, no tender or swollen joints, no stigmata of connective tissue disorders or vasculitis, and systemic examination was largely normal. So to summarize, the syndrome is a middle-aged man with a classical pyrexia of unknown origin with pallor and axillary lymphadenopathy and significant weight loss. So differential diagnosis we considered in this gentleman, chronic infections like TB, brucellosis, HIV, enteric fever, infective endocarditis, malignancies that cause fever like lymphoma, multiple myeloma, RCC and HCC, connective tissue disorders, vasculitides, granulomatous diseases like sarcoid, and other causes of fever like pulmonary embolism were differentials that we considered. Investigations wise, he had microcytic anemia, he had thrombocytosis, he had a raised alkaline phosphatase level. Bloodborne virus screen was negative. He had microscopic hematuria and bone marrow, serial blood cultures, induced sputum for TB expert, echo, they were all normal. ANA was negative, ANCAS complements, ACE levels all negative. Gastroscopy was normal and he's yet to undergo colonoscopy for evaluation of the anemia. To note here was that he had a slightly deranged INR with no features of chronic liver disease. We attempted a correction with 3 days of vitamin K, but it still remained the same. In view of this elevated alkaline phosphatase, we had done a GGT as well, and that was elevated at 180. So we went ahead with a PET CT and that showed a large heterogeneous mass at the left. This is the left kidney and there's a large mass that is involving the left kidney and as well as the left adrenal gland. And there is an equally metabolically active mediastinal nodes that are present. And he also had a solitary nodule in the left upper lobe of the lung. So we thought this looked like a renal cell carcinoma with metastasis to the mediastinal nodes and lung. Causes for an elevated alkaline phosphatase that we considered in this setting were malignant obstruction by nodes, infiltrative disease of the liver, metastatic carcinoma to the liver, bone metastasis, but GGT was elevated, so that was unlikely. Stauff syndrome and drug-induced cholestasis, but he did not have history of any offending drugs. So we went ahead with he didn't have any liver lesions. So we went ahead with a non-targeted liver biopsy, which showed mild mixed portal inflammation and mild focal bile duct damage. So basically a mild intrahepatic cholestasis. So the diagnosis was actually a probable metastatic renal cell carcinoma with Stauff syndrome and iron deficiency anemia. So Stauff syndrome is a paraneoplastic syndrome that is classically seen with RCC, but can be seen with other malignancies also, first described by an American gastroenterologist called Morris H. Stauff. So removal of the primary tumor actually improves all the abnormalities that are seen in Stauff syndrome. I'll come to those. So that's why it's called that is why it's classed as a paraneoplastic syndrome. It typically consists of an unexplained hepatitis with or without jaundice and with or without cholestasis. And there is no evidence of infectious etiology, neoplastic involvement of the liver or bile ducts. The resolution of hepatopathy is noted after removal of the primary tumor. The most common abnormality that is seen is an elevated alkaline phosphatase seen in 90% of the cases with Stauff syndrome. You can also have elevated transaminases as well as a direct hyperbilirubinemia. Usually they are anicteric, but there have been case reports of Stauff syndrome who present with icterus as well. Other laboratory anomalies that are noted are an elevated ESR, elevated GGT levels, thrombocytosis, and prolonged PTINR, the last 2 of which our patient had. The pathogenesis that is postulated is a IL-6 interleukin-6 mediated inflammation of the bile ducts of the liver, and there is also postulated to the renal cell carcinoma itself is postulated to release lysosomal enzymes which cause intrahepatic cholestasis, and there have been studies that showed that in RCC CRP haptoglobulin levels are elevated. That can also cause a intrahepatic cholestasis as well. So our patient is actually being transferred under urology for a renal biopsy and a total nephrectomy, and depending on the biopsy, he will undergo immunotherapy further to that.
Did we do any other investigations before PET?
The bloods that I had mentioned were done, sir. Bone marrow.
Scans, any scans we have done? Radiological investigation, ultrasound.
We had an ultrasound. The ultrasound also picked up the renal mass.
Ultrasound. So liver biopsy, why did we do?
We did because
there's a PET-CT uptake.
No, there was no PET uptake in the liver, sir. We had to rule out another concurrent granulomatous etiology or infiltrative liver disorder. That's why we did there was no liver lesion per se.
Oh, why we have to do liver biopsy? Because we know that it is arising from renal, right?
We haven't proved the histology yet, sir, but on the PET, it looks like a metastatic renal.
Just based on the biochemical parameters that liver is involved, we are doing a liver biopsy here. Okay, any comments from audience? I think we may have, we should have maybe tried to find out what is the renal lesion.
He will undergo a biopsy.
Yeah, that's what. Maybe after that, but before that itself, we have tried to do the liver biopsy. I don't think that is. So how is he now after liver biopsy?
He's okay, sir.
Okay. Drug or a toxin induced, they said, no? Possibilities. Possibilities. Intrahepatic cholestasis. So we are assuming that probably it is a renal cell carcinoma.
Yes.
That has a systemic paraneoplastic effect on the liver.
Yes.
So that we are calling it as a Stauff syndrome. Can you just say again? Can you just highlight what are the points? Stauff syndrome.
Elevated PT-INR, elevated alkaline phosphatase, thrombocytosis, elevated ESR. Can also have hepatitis and direct hypobilirubinemia.
So it is standardized, is it?
Yes.
Criteria to diagnose Stauff syndrome?
No, it's not like a criteria for diagnosis. Along with renal cell carcinoma, if you have these abnormalities and you are able to disprove other involvement of the liver from metastasis or other infectious causes or drugs, then we can call it Stauff syndrome.
Any other malignancies it's been reported?
Multiple myeloma also, I saw some case reports, most commonly with renal cell carcinoma, but I saw some case reports with multiple myeloma as well.
So what is the significance of this, identifying the Stauff syndrome clinically? Can we predict that clinically? Let us say patient with constitutional symptoms, you suspect a malignancy and has clinical, probably biochemical features of Stauff syndrome. Does it tell you anything that it could be this malignancy? No, that whether it could be this, it cannot tell, sir. And I couldn't find any direct relation to prognostication also. Some of the things that happen in Stauff syndrome, the anemia and all is used in the prognostication of RCC, but directly not Stauff syndrome as a whole. Yeah, thank you. We'll move to the next one. Any other comments?
Good morning, everyone.
Sorry? Question. Oh, okay. Did we know about Stauff syndrome before liver biopsy and how common is it?
Yeah, we did suspect Stauff syndrome because we had the PET report before the liver biopsy. We knew that it was a mass arising from the left renal. How common is it? I just have to look up that number. exactly how many RCC cases that were shown.